4. It is 2:34, so we will call the SCRILS meeting together on December 3rd. Welcome everybody as we can kind of look on the different boxes and list of attendees for the roll call, and then we will move into our first agenda items. As Kathleen mentioned, Amber Leaders was unavailable from the governor's office. So we'll move to item 2B, which is Washington State Healthcare Authority, and Michelle, Jason, Megan, and Suzanne. I will hand it over to you, and whoever would like to lead off, just feel free to take it away.
Thanks, Commissioner Kearns. Appreciate the time this afternoon and good to be with you all. This is Jason McGill with the Healthcare Authority, Director for the Medicaid Programs Division for HCA. I think we've had the pleasure of visiting you in the past, similar issues, unfortunately, just the continuing issues with regard to challenges with behavioral health workforce and the complexities in our healthcare system, particularly post behavioral health integration. The issue with regard to United Health's recent request to expand into the Spokane region and other Eastern Washington regions, in addition to, I believe, Southwest Washington, has caused some consternation with certain providers, certainly understandable considering the complexities to the system. Ones we're trying to, of course, improve upon as the I think integration and managed care really does provide value for our members in the system overall. But as you know, we're only really at the end of the beginning with regard to improvements in that system. So a lot of work is still necessary. And then combine that with COVID and workforce shortages and challenges, as I think others will talk to a little bit more about here shortly. It is just complex. So United Health, and I really appreciate the CEO, Genevieve Grancho Simpson, informed me that she is not pursuing that expansion request as of for 2023. I think I appreciate that decision, considering the complexities and considering some of the feedback that we heard from particular members in your region. That said, she's very interested in working with certain providers in the region more for potential future expansion, and I would greatly encourage that. I suppose at that I will pause and see if there are any further questions about that issue number 1 there.
Jason, this is Kathleen.
Hi, Kathleen.
Thank you for responding to our question in that regard. Can you elaborate a little bit more on what you mean by that the executive will be looking at it with regards to some providers in the future? Does that mean she's going to be looking and making that request in a future year, or is she reaching out now? I guess I'm just trying to make sure.
I don't know. Right. I don't know for certain, but generally, I think she is interested in continuing to develop the relationships that may be necessary to support expansion. And as you know, I think that's incredibly important, not just for the behavioral health space, but for healthcare generally. As our Medicaid members transition, often in terms of income level to individual market, and as they age, when they turn 65, they age into the Medicare Advantage plan, and many become dually eligible. We need to have coverage throughout the market, throughout the health system. And so I just encourage continuing conversation, and that was Jen's request. And so Kathleen, not certain how to proceed there. If any of your members are interested in, say, connections or introductions, I would be happy to do that.
Well, I do think she has actually approached some of our providers, if not all of them, as well as the ASO. And so I think the important part is that for our providers to just know what your plan is and what you're doing. And it sounds like you're not doing anything for 2023, so that's good. From a standpoint, I think really the position of the providers, as they have conveyed to in the past to HCA as well as to ourselves, it's that administrative workload. And when you've got a workforce shortage going on and a pandemic that we're all trying to deal with, it's just an extremely challenging time for them. And so I appreciate that she is willing to wait on that. And so I think that will be good news to our providers who were very concerned about that additional workload to their administration with regards to having an additional MCO in the region. So we appreciate that and that consideration. And I would just ask again, going all the way back to our commissioner's original letter of support to go into integrated managed care was a great concern around this. And so I would ask that HCA would provide the members of the Spokane County Regional Interlocal Leadership leadership team with some advance notice, either by letter or other communication, so that we know when it is being seriously considered again.
Absolutely. Thanks, Kathleen.
Thank you.
So Kathleen, I think, let me see who else is on from HCA to help with some of these other questions. And well, hi, Michelle. I see Michelle Wilsey from our finance division, Steve Perry from our behavioral health division, Katrina Lucero, deputy CFO. Hi, Katrina. Teresa Claycamp, really our special assistant for behavioral health integration. Hi, Teresa. So I think you've got a great team. Did I miss anybody from HCA? Oh, hey, Suzanne's on as well. Our sort of nurse policy workforce experts. You've got a great group here. I'm not sure how you'd like to proceed. Or please chime in, team.
Katrina, did you want to take the lead on these questions?
Sure, and I think that some of these topics are covered in the September meeting. Is that correct?
Yeah, there was some conversation, but I don't know that we fully answered all of the questions. So I think that's why they came back.
Okay, so is the desire to kind of go through each one of these again, or are there places that we should focus?
And maybe, Katrina, we could do sort of the high points and then pause for questions or Kathleen, do you have a preference how to proceed here?
Jason, no, I agree with that. Hit the high points, ask for questions, because I unfortunately was not able to be present for the September meeting, but some of the feedback that I got is that there was a feeling that the questions were not fully answered. So I think hitting the high points and allowing individuals to ask questions, I think, is a great approach. So thank you.
Maybe Jason, I can start and you can add
Yeah,
whatever color I sort of missed.
Please, thanks, Katrina.
Yeah, so I know people are aware that we are sort of coming to the conclusion of our managed care rate setting process. I also know that people have frustrations about not feeling like that process has really incorporated enough of the feedback that we've received around workforce. And as you know, unfortunately, the managed care rate setting process may not be the most appropriate form for that. You know, that said, we did get that 2% provider rate increase that went in April of last year. Again, recognizing that 2% is a very small amount of money, so it may not be particularly material. We're also, you should know that the part of the managed care rate development process does include unit cost trends, which in part should help when MCOs are contracting with providers to recognize the fact that those services are now more expensive. So there is a little bit of help there. But again, you know, unfortunately, the managed care rate setting process is just not really the place that we think we can really help address some of the workforce issues. That said, one thing that may have been discussed last time that we are working on and that we're actively engaging providers on is our behavioral health rate comparison study that we're doing this year. That work launched back in October, and the goal there is really to work with providers to better understand, you know, what is the actual cost of delivering services from the provider's perspective. And then we're going to use that information to help develop the set of comparison rates. And I think that will really help us as we move forward to better understand sort of the lay of the land, and then also be more strategic when we think through about what sort of policy decisions we like to see going forward, and help us think about some of the decision packages as we might bring next year. I don't know, Jason, do you want to talk about how that might translate into some of the work we're doing on the CBHC model potential issue this year?
I think that's exactly right, Katrina. And just to, if we can develop some additional baseline data, such as Katrina mentioned, through this behavioral health rate comparison work, which we have begun and working with providers and small groups now for SUD, residential SUD outpatient, and mental health outpatient. Those are the three we've prioritized right off. And I really think that will provide us a good baseline data to then consider what changes are necessary, data-driven. And for example, that could be alignment with the CCBHC model. This is a Certified Behavioral Health Center model. A few clinics are piloting now some really promising results nationally. The congressional legislation has that as potential expansion. So this may be good information to help align that if our legislature wants to advance that, and or other rate increases, targeted rate increases, other items that may be, again, that work may help in terms of data-driven approaches to your, particularly to your first question. What can providers do? Katrina's right. This is a difficult situation in terms of rate setting, in terms of state budgeting. The legislature sets the budget, of course, as you know. Managed care, there is some flexibility to adjust rates accordingly to what is paid. What is the evidence of contracted rates between providers and managed care plans? So absolutely get that evidence in, and the plans are all responsible to do so. But beyond that, it is hard to go outside of the legislative process to amend rates accordingly. And so really it is a legislative issue above and beyond what is sort of forecasted and dealt with under managed care rate setting. So anyhow, a lot there. Let's pause on that one. Others might like to chime in before, I think we're going to pivot a little bit to maybe workforce here next. Michelle, Teresa, other thoughts?
No, I think you covered it, and I think it should be noticed that we do have a lot of legislative mandates that are requiring us to do some of this additional work, and so we are working through those things one piece at a time. And our group is well aware of what's going on and working through the information that we have and doing the work.
I agree. I think the mandates, for example, you're talking about, there's some transparency requirements. So we're committed to working with providers in open forums and having very detailed presentations from our finance team, Michelle, Katrina, others, and our actuaries to detail the rates. Again, as part of or in combination with the rate comparison study work, I think that transparency is significant. And that may be an evolution, right? So that wasn't exactly perhaps what you saw a year or two ago. And so we're slowly but surely here improving upon so that level of detail and just that sharing and collaboration and open forum, transparent forum in that regard. And I think that might cover 1 and 2. 3 is getting into a little bit of both as well. Katrina, Michelle, anything we could talk about in terms of current rate setting? Katrina, you mentioned the 2% increase began in October, is retroactive to April. That is well underway. The managed care plans have committed to making sure those contracts are updated and those payments are made ASAP and no later than by the end of this year. I know it is tough to wait in this environment for any rate increase, but it's also very tough for the system to pivot on a dime and to really update contracts and change payment systems. But so I think we're all doing the best we can in that regard. Please.
One other thing I might add is, and again, recognizing that the money may not have been sufficient, there was money in our most recent budget, I believe it was $31 million for provider relief funds. You know, those were distributed through sort of a grant application process and did go out in October. So again, recognizing that it probably was not sufficient to really address the issues that people are facing, but it was one thing that we were able to do to help some providers out.
Yeah.
Jason, also there is a question in the chat that came through. The question is, how does the Medicaid 1115 waiver supplement or support the rates?
I think that's an interesting question. I would say in a few ways, but not directly. So the waiver supports behavioral health integration, supports capacity, supports ACHs to help build workforce capacity to some extent, certainly supports opioid treatment and building, again, capacity in that regard. It also builds, again, supports ACH, this accountable community of health work on a regional basis to support health equity initiatives and to really connect with non-health care in the region to help with those healthcare related social factors. And so there, I think, is some significant, perhaps indirect connection to the Medicaid rates in that regard.
Others, if I may,
please.
Oh, if I may, you know, I think the other linkage there that, again, not direct, but I think has an interesting indirect impact is that waiver does support our ability for those foundational community supports work, but really help us kind of, you know, keep people employed, help them find jobs, keep them housed, help them find housing. And as you all know, those types of social interventions can really help with people's behavioral health needs as well. So again, not a direct linkage, but it has definitely been helpful in terms of thinking about whole person care.
And I would say too, I don't always look at what we call initiative 4 and 5 of our 1115 waiver, which is the SUD and the mental health IMD waiver, sort of granting additional federal support, federal funding for what was otherwise non-Medicaid IMD related services. Again, perhaps not directly as part of the rates, but it does free up some state dollars. The legislature might then be able to say, okay, we can raise rates by 2%. And that I think is helpful in that regard. Other thoughts from folks? I know, Teresa, you live this day in and day out with our partners and provider for years. Any thoughts on all of this here?
Thanks, Jason. No, I'm glad you tagged initiative 4 and 5, because I was going to mention that allows us to leverage Medicaid and frees up those general fund state dollars in a way that is helpful. So, and I think foundational community supports too. I don't think people realize how important that is in our state, in that it also is keeping non-traditional providers at play. A lot of those providers that do foundational community supports are actually not our behavioral health agencies. And so I just think it's important to support the workforce from a wider standpoint, because those are really important providers doing that work. So indirect, I guess, as Jason, to your point, that it's not direct, but it does have a impact, I would say.
I agree.
Jason, question I have that I'm sure you answered in there with your remarks, but I just wanted to confirm or clarify. So as the rate setting process is going forward, as you're meeting with the providers, which I think is absolutely excellent, that is going on, is it through kind of a couple of lenses, the fact that there has been potentially insufficient funding for the behavioral health providers for longer than just the last 2 or 3 years with integrated managed care, and thinking about making sure that what we have basically the house is running before we are adding, additional programs and things like that. We very much appreciate that there's more funding coming in. There's also more programs coming in and being established, and that's all good and wonderful, but we want to make sure that just the main house piece is healthy and adequately funded. And so, has been pointed out, 2%, and it has been mentioned by our providers in the past, 2% isn't even covering, operational increases, much less, the recruitment and retention challenges that are being faced with the workforce shortage. So can you kind of go into a little bit more detail with regards to, I know you've been having a lot of meetings and taking in a lot of information, but some of the questions we've been asked by providers when we've been trying to RFP and contract out some of these programs is, we can't go any further. We can't extend ourselves any further. We don't have any more staff. We don't have anybody that we can then take from another program to put into a new program. So it's kind of that kind of issue at times in the challenges that we as an ASO, as well as probably the MCOs, I don't want to speak for them, but that really our providers are facing is, can we sustain this as well as all these new programs, given the workforce shortage and potentially insufficient funds for just their main piece. Again, with the workforce shortage, they may have some, more funding because they don't have the staff costs, but if they are to ramp up to what is required and needed, there's that balance. So what I was wondering is, with the rate setting process, are both areas being contemplated, not just expansion, but also the health of the existing programs?
I think it's a couple of different thoughts on this. One is again, sort of Katrina's earlier point, the rate setting process is imperfect in that regard. It is not a strategic policy and programmatic effort. It is looking at the rates, what's paid, looking backwards and projecting forward based on that data. We do have some flexibility in that regard in terms of assessing trend and assessing acuity of the members, certainly adding new programs. I think to your point, though, that is, in my view, more strategic and program focused and policy driven, the sense of legislature, you've got to make sure we can do what we could do before you add something new. However, the legislature's also added something new, like peer supports, using non-traditional providers and finding ways to extend that service. I get it, it's still hard to find and staff and train and so forth, but I do think there's some strategic effort along those lines, and I think we've obviously begun that work. Navigator's another example of that in the ASO realm for crisis and sort of the response to the Blake decision work. But I hear you, Kathleen, and I do think we're quite cognizant about that at HCA because we feel it too. We do not have the staff at HCA to continue this level of a new programmatic development. It's a real challenge. So I think it's a balance. I think it's strategic. I think it's a conversation with the legislature in that regard to really balance those needs there. And I see Commissioner Picard.
Trying to unmute here. Sorry.
There we are. How you doing?
Doing pretty good. So I realize that there is a lag between the legislative session and what they do and where we currently are in the environment that we're in. But when the CPI is running 5.8 plus, and we're looking at a 2% increase, obviously we're way behind the curve as far as keeping up. And again, this goes to the shortage and retention, and you're literally pulling money out of whatever reserves you might have left to try and keep up with the increase in the insurance rates alone for your employees, let alone, the 2% increase in salaries that we could move forward. So is there any thought of going back to the legislature this year and talking about that some more? Because the last 12 months have seen a
absolute
drastic change in life as we know it.
I think, Wes, we'll see the governor's budget here shortly. say what the governor does first. But I think inevitably that conversation will occur this legislative session. I know the Behavioral Health Council, not sure, I'm sure there's folks on from the council today who could chime in that I understand they're advocating, hey, Jeff, they're advocating for a 7% rate increase. So I know that that conversation will be very, very loud and clear. Jeff, please.
Yeah, no, I was going to say exactly what you're teeing up for. This has been a very robust topic of discussion, passionate topic of discussion for the council at large, for the board members, and those of us on the strategic planning committee for the board. And absolutely 100%, we're going to push as hard as we can for a 7% increase, Medicaid rate increase this coming year. And it's also a point of discussion that we've very much visited, is that part of the messaging to the legislature is to not mistake a request for a 7% increase with that being a solution to the workforce shortage. That is a, at best, a life raft, a very important life raft, but nonetheless, not a longer term or even mid-range solution.
I think, Jeff, just maybe an opportunity there to highlight again, the rate comparison study work gives us foundational work, gives us data, and then the other decision package that we did advance, and pretty optimistic we'll see that in the governor's budget, but we'll have to wait and see for sure, of course. The CCBHC option, the Certified Behavioral Health Clinic option. And I do think that holds potential for that level of sort of systematic change for building future. Now, is it going to be near term? No. This is a study. This will be doing the foundational work necessary to then let the legislature decide what to do in terms of rate sustainability, meaning improve quality and access of behavioral health through certified measures and outcome measures for exchange of what is called prospective payment rates. So this is basically cost-based rates. We do not have a cost-based system today in Medicaid, except out of our community health clinics or FQHC clinics, and to some extent our hospital clinics or critical access hospitals, rural health clinics. So if the legislature chooses to implement that option, that could be a very significant long-term solution.
Hey, Jason, quickly, just before we go to Steve, who I think is going to give some updates, just on that 2%. So the 2% was the sort of direct piece of legislature funded in terms of provider wage increase. But I will say, and again, the trends are not finalized yet, but one thing we do for each year in the managed care rate build is there are trends built in for unit costs that in part can help with some of those wage gaps. Again, recognizing it may not be sufficient, but I just wanted to put a plug in there that there's not just the direct 2%, but there is some money in there for those unit cost increases that we see year over year. So I don't know, Steve, you want to give your update on workforce?
Yeah, I'd be glad to. And I know I've shared some of these with this group before, but you know, lots going on, and always helpful to be reminded sometimes, I think. But and I want to say going in that this isn't enough. We need to do more, and I know my colleagues at HCA are committed to doing that more, and we're working with lots of partners across the state to address some of the workforce shortage issues. And what I'm going to share is not a comprehensive list by any means, but just sort of an acknowledgement of some of the different areas that we are investing. And some of those include, you know, our behavioral health marketing campaign. We received funding to extend that for a phase 2. So we'll be expanding on those efforts, acknowledging that a campaign like that is not going to produce a short-term high impact effect, but we need to get more people in the field, and that's what we're trying to do through that campaign. We're working with a group of stakeholders to develop, as Michelle Wilsey mentioned earlier, teaching and clinic enhancement rate for behavioral health providers who are training and supervising the majority of interns in the industry. And that is a rate process looking for potential costs to a provider that aren't already included in the rate structure, in addition to developing some standards for what a teaching clinic might look like. We worked with a group of stakeholders a couple of months ago to examine the impacts of criminal background checks on the behavioral health employment settings, and we'll be putting together a report for legislature by next month, I believe, on some of that work. As you all know and have talked about, we are moving significant financial investments out into the community because there's that opportunity currently with federal and state giving. But again, understanding that pumping out dollars for services and programs is great and it's needed, but it also puts pressure on a workforce that is suffering from significant shortages right now. Looking at this here, we're doing some work with our community and technical college partners to look for opportunities to expand educational programmings, make that more flexible, building bridges between them, developing articulation agreements. Of course, there was 31 million for provider relief fund. Again, acknowledging that it's not enough, but it was an opportunity to get some money back out into the community where needed. We are more recently began working with our partners at Department of Health to begin to dig into some of the licensure delay issues, and they have been really great partners in that process. They did let us know that they are in the process of bringing on 34, I think, new staff who will be working in and around the licensing application process. So although it'll take some time to get those folks up to speed, we do expect to see some improvements in the application process, hopefully in the coming months. Number of legislative provisos. One of those provisos came out was described in House Bill 1504, which creates 3 pilot programs for community behavioral health agencies. Again, focusing on supervision. The money can be used to increase salary or provide incentives for supervisors and cover costs of the work involved in bringing on and training and supervising interns. It also dedicates a portion of those funds to some flexible funding for industry-led training, because we know significant investments are made in the behavioral health system in training. So that will help with some of that. And the thought behind the 1504 programs is to go back to the legislature with recommendations for how we can replicate, expand, and support ongoing investments in areas like this in the future. So again, those are just a small sampling of some of the things that we're doing, but a lot of work going on, and appreciate the situation folks are in.
And Jason, if you'd like me to, I could comment on the answer to question 5 with the program situation. One of the things that we have done in the last year or so is to create what we call the spending plan, allowing the ASOs to utilize, and also the MCOs to utilize their general fund state funding beyond the contract period by asking for some exceptions. And so we have this spending plan. Our intent is to get the money out as quickly as we can, but sometimes we have complex funding that goes out in different methods that we have to do a lot of research to determine how best to send it out to the regions. And so it takes us a little bit of time once the legislation is passed to actually create those models and make sure our projections are accurate based on who's getting what money and population base. And so we try to send the money out as quickly as we can, but then we also try to give the opportunity to utilize that money beyond the scope of the contract, recognizing that it takes a bit of time sometimes to get those programs up and running, and allowing for some additional consideration of time to be able to do that. Hopefully that's helpful.
Michelle, thanks so much. Any other thoughts for Steve or Michelle or others? And maybe I'll just chime in too on the 1310 really quick. I unfortunately Carrie couldn't make it, but she confirmed with me anyway this morning that there is unfortunately nothing more to report. This is a legislative item now. We're collecting the data and through some surveys. Thank you to the ASOs across the state who are really helping coordinate some of this effort with our providers to understand what we're seeing with our DCRs and so forth. And that'll be provided from statewide data to the legislature for potential further policy change.
So Jason, this is Kathleen. I am aware that at least that our region, we have sent out, not only ourselves, but providers have sent letters to our legislators to give them examples and of what has happened and data, if we have it, with regards to the impact. So we've been doing a lot of educating of the legislators from our region in regards to the impact. And we do know that they are looking at potential changes and that type of thing. I was just wondering, it's helpful to know, what is HCA doing as far as anything to do with the legislators? Are you involved with that? Are you advocating? Are you just waiting to be told whatever the legislation decides through the next session? I wasn't exactly sure. I do know that you're obviously collecting and sending out reports and appreciative of that. But I was just wondering, is there anything else that the HCA is doing that we should be aware of?
I don't think so, Kathleen. I think we're trying to stay in close contact, particularly through the ASOs. And I'm just reading my note here from Carrie to see if I missed anything. I think that, yeah, no, I think we covered it.
What I'm aware of is just, I know that there are legislators that are looking at introducing clarifying language into via bill. So that's just what I'm hearing. I haven't heard anything specifically. It was all draft that was shared with me, but that's why I wanted to know whether HCA is being consulted on that or involved in that whatsoever. Okay, thank you. I think there may be a question out there from Blake. He has his hand up, and then Jeff Thomas after that.
Yes, thank you, Kathleen. I just have a comment / question for Michelle and Jason. Michelle, you were talking about the expansion of general state funds, to look at these services that that are provided with non-Medicaid dollars. I did reach out to the HCA. It's been a while now, and I didn't get any response. But we do operate one of the only sobering services in our region, and the increases, according to the MCOs, of course, where we can't get increases because of the lack of dollars that are out there from the HCA, and I get that. But with 1310, especially with the lack of response and the more the community is relying on behavioral health organizations to kind of pick up the slack, we're suffocating basically. I've had to combine programs, cut staff, cut hours. So I'm just curious to hear more upon that expansion and what that's going to look like, and I would love to have a conversation to be to actually be a part of that, because I haven't heard nobody's reached out to me as a provider that provides a lot of these non-Medicaid services to the community. So yeah, I would just love to have a conversation about that before it moves forward to what the actual need is.
Michelle, I think you're on mute there, are you? Yeah.
Sorry about
There you
that.
are. There you go.
We did get significant funding through the Blake legislation for additional services. that is going out to the ASOs and for a lot of services in this regard. So I think that's something that we can take back to talk about how that funding is being implemented in your particular region.
Well, and no relation, Blake, but the Blake bill and the ongoing public committee related to that may be a forum we need you at to help with that sort of communication. And I'm going to venture a guess here that folks like our Behavioral Health Director Carrie Waterland and our Deputy Director Michael Langer will want to hear from you a bit more about this. And I'm happy to either schedule some time about just take that on right off, or Blake, you can let me know what you might be interested in how to follow up.
Okay, thanks, Jason. I'll shoot you an email after this.
Yeah, and I think if the plan or discussion is centered around, funding to the ASO, that we would want to be involved in that conversation as well too. Not necessarily the representation, Blake is, fine as the provider to represent on those types of committees, but if we're actually specifically talking about funding to the ASO, we'd like to be a part of that discussion as well. Thank you. And then I think Jeff Thomas has his hand up next.
Thanks, Kathleen. Just to follow up on some of the comments with regard to 1310, our experience as having the DCRs reading the ITA evaluations and detentions for Spokane County is that it continues to be we see a significant reduction in the number of detentions. And I don't have the most recent data, but it was between 35 and 40% reduction in detentions. And we know our community didn't get that much healthier all of a sudden. So, that's between 70 and 80 individuals in any given month who are or would be meeting the criteria to be detained under the ITA laws who are not being, whether it's because we evaluate them and they can't be taken into custody, or we aren't even able to evaluate them because law enforcement isn't able to or willing to accompany us. We're also seeing and continue to see a significant negative impact on our census on our 2 ENT facilities. A quite significant negative impact in terms of reduction in census. And I know that both of those issues are ones that are being experienced by providers across the state. Not news to you, I'm sure, Jason or others, but just in conversations, I'm probably in at least 1 or 2 conversations a week with other providers around the state, and it's absolutely not unique to our region or to us as an organization. So, and I think so we have the safety to the community and safety to the individuals issue, and then we have the financial impact, which may not be of tremendous concern or the paramount concern to folks, other than if it begins to erode things to the point where it compromises the ability of these facilities to be in place once things get remedied, under the assumption that they will. I think we all want to see those programs still be viable, because again, we know there's going to be that need. I will share that I had the opportunity to be in a discussion with Representative Johnson, one of the prime sponsors of the legislation, and just a few days ago, and I and a few others were in conversation with him about the work that he is actively involved in on creating clarifying revised language on 1310, such that it would address the concerns on the part of law enforcement and essentially allow them to feel comfortable in resuming their involvement, as it has been in the past, in detentions and taking individuals into custody. And it's quite a process for him and others to go through, because it does have to absolutely be something that's worked on in concert with law enforcement, because if it doesn't satisfy those groups, then it really isn't going to accomplish what it needs to. I did ask him how soon in the session this is going to be addressed, and how quickly he anticipated potentially it could be signed and delivered and put into law. And his response was that in the very first few days of the session, it was going to be introduced, and then it has to go through the chambers and the governor to sign it. But under an emergency clause, he believed that by mid-February, assuming mutually agreeable language can be arrived at, which it darn sure better be, then by mid-February, the change could be in effect, which would be phenomenal. So to whatever extent that's helpful for others to hear, I thought I'd offer it.
Jeff, thank you. And I'm sorry, which representative was that you had spoke with?
It's Representative Johnson.
Okay, thank you. I had heard that Representative Goodman may be working with legislators that maybe Representative Johnson on the clarifying language too.
Yeah, I think it's a team effort. Mhm.
Hey,
Jeff, I
Jeff.
see it. Hey, Dan.
Hey, Jason. Hey, and Jeff. That's really exciting to hear, because as soon as a little bit ago, when I heard someone say about clarifying language on HB 1310, I was the first one to throw something in the chat, because as you and I both know, and everyone statewide, it's significantly impacted the safety and well-being of citizens and the community. And the statistics on less detentions has nothing to do with people getting psychologically healthy in the middle of pandemic stresses, as we all know. So I'd love to know as that progresses. And man, I sure was excited when you just said there may be an emergency clause in order to put something into place by March.
Mm-hmm. Yep. Yeah, and he said he was hopeful that by mid-February, so we will see. But there's, I think there's no lack of understanding or appreciation of the acuity of the situation. There doesn't appear to be anyway.
I can say, so the optics are that the legislators understand the seriousness of the situation.
That's my sense. Yeah.
Oh, that's great to hear. Excellent. Thanks for the clarification.
Yeah.
Great.
Well, I really appreciate HCA and everyone, speaking up and with regards to these questions and topics that we had specifically for HCA. So I think that's been very helpful. I think this has been a great discussion, and I may keep some at the high level, maybe not the detailed questions, but keep some of these high level topics on our agenda for the next SCRILS, because they're not going to be solved, as we all discussed, they're not going to be solved overnight. But I think keeping our hand on the pulse on these with HCA's leadership is important to everyone involved. So I'll go ahead and keep those on. And then I think, unless anybody has any other questions or comments, we're kind of running a little bit past time. I think if there's nothing further for anyone, if anyone has anything else, otherwise I think we're ready to move on to item 4, Commissioner Kearns.
I just want to, Robert Rosenkrantz, a clarifying question. Did I hear correctly that emergency powers are being it's being considered to invoke them to when there's legislation that's currently pending to address the same subject?
I don't know if that's harkening to what I was describing in 1310, but what Representative Johnson said is that he believed the changes in the amendments to 1310 could be expedited under what he referred to as an emergency clause. And I'm not intimately familiar enough with all the nuances of what that means, but it sounded as though it's something that helps to fast track.
Yeah, so this Commissioner Kearns, what an emergency clause would do is traditionally when legislation is adopted during session, it waits until around June to be signed by the governor. If there's an emergency clause, it kind of fast tracks it, so the governor will sign it as soon as it is adopted by both chambers, rather than having it sit and wait until after sine die and until, whether it's 60 or 30 or 60, 90 days for implementation. The governor will sign it into law immediately upon passing both houses.
That clears it up. Thank you so much.
Yep, no problem. Okay, so Kathleen was saying we can move on to item number 4 if there's nothing else on this topic. Number 4 is looks like an update on Senate Bill 5476 and engross second substitute House Bill 1477. So Justin Johnson, I will hand it over to you for a presentation.
Thank you, Commissioner Kearns. Justin Johnson, I'm the Assistant Director here with the Spokane County Community Services Housing and Community Development Department. And just giving you a brief update on what we're doing here currently within the Spokane Regional Service Area to implement different programs coming down for 5476 and our work with 1477, which is the 988 implementation within our region. So starting with the 5476, the Spokane Regional Community Services and Housing Community Development Department just submitted a RMP Recovery Navigator program implementation and selective procurement process for our 6 county regions. And out of that process, 3 were selected. New Alliance, which is Northeast Washington Alliance Counseling Services for the Ferry, Lincoln, and Stevens counties. Pend Oreille County Counseling Services for Pend Oreille, and Pioneer Human Services for the Spokane County region. And now this is a really big program. It, again, implements a lot of this navigating the system and supporting individuals in between systems who may not be involved or directly engaged with behavioral health providers to engage them with them. Those coming out of jail settings, out of hospital settings, and those being transitioned into maybe just needing resources. And so those are key areas where this program will help. It's quite a bit of money, especially for our frontier rural communities, and allows for transportation and really some great changes to really filling in gaps, especially for those coming out of the criminal justice system. Again, the focus is SUD and SUD involvement and working with the courts for diversion or pre-arrest engagement. So super exciting. Adams County, we did not receive any applicants for the RFP that we put out. That is currently out again for providers within Adams County. And then after those 2 rounds, we'll look to next steps with the healthcare authority as to what we should do if no providers come forward. One of the biggest challenges was the concern about workforce crisis and being able to field a team. And the way we pushed it out to our providers to support them is really just leveraging existing resources. And so in this way, the program has been significantly beneficial, I believe, in the way that has been put forward to ensure this program is successful without overtaxing a region or draining resources from other projects that are currently going on. Again, that work is ongoing. We hope to begin starting January 1st. As to the 988 project, this is a little bit more expansive, and a lot of individuals on the call here are already involved in different aspects of this. So I'll just speak briefly about our involvement and some of our providers in the community. As many of you know, Frontier Behavioral Health is one of the crisis line providers that has been selected by the state to be one of the crisis line hubs as part of this overhaul of the crisis system and 988 call system that will be going into place here in the next couple of years. And as part of that, Jeff and his team have been heavily involved in the process of subcommittees and providing feedback and information to the state as they begin developing an infrastructure and looking at the aspects of how that will look when a call is received and then put out to our region. So recently, we've been having CRIS committee, which is the Crisis Redesign Committee, which will provide feedback to the overall steering committee who makes the decisions for this 90-day. So the Spokane Regional BHASO is one of the CRIS committee members. So is Frontier Behavioral Health and a lot of other providers in our community. And as part of that, there's also subcommittees that work to provide information and support to the CRIS committees that then put those reports up to the steering committee, who will ultimately make the final recommendations and decisions for how this implementation goes into effect. And through the work that we've been pushing out for development of the subcommittees with the healthcare authority, we've really encouraged our local providers to join in and support being a part of that overall conversation, because it's statewide. And one of those that we were successful in getting created was a Frontier Rural subcommittee that looks at just the needs as it pertains to frontier rural communities, as well as crisis system redesign, which again, a lot of our providers are on. And so through these successes, we've been able to have a strong voice from our region, and not only from Spokane County, but also our outlying regions, which will be impacted for the implementation. And so from that aspect, I think there's a lot of great work going on, a lot of stuff still needing to come forward, but we're pretty much from our regional perspective, doing our best to ensure a voice at the table so that any implementation or changes that are going into effect have that Spokane regional service area input. And I'll turn it over to Jeff. I'm sure he has a lot to share on his involvement as well with the 90 Day.
Yeah, so we're going till 5, is that right? Or I think you've covered it pretty well as far as a flyover, but yeah, the committee and then the subcommittees, and I think we've got 4 staff participating on various subcommittees, everything from the technology end of it to the crisis system redesign. I almost put quotes around that issue, to the rural interests and unique aspects of and needs of rural communities, which is really important. So we signed somebody up to be on that to do our best to try and help represent that voice. And I think it's it's going to be complicated, and it's going to be a pretty involved process. And it's I think we've talked about this before, but I think it bears reiterating as we've talked about workforce shortage challenges. There's some pretty ambitious visionary goals, aspirational goals associated with the 1477 legislation, which is built upon the federal 988 line legislation. And much, if not most, if not all of it is, I think, got some really good potential and some good concepts. But there's always the challenges that when you get to the details. And I think that's where some of the heavy lifting and the real work has to occur. And some of that has been occurring with some of the surveying that's being done of providers in different regions, just to help understand if the part of the intent of the 1477 legislation is to enhance the current crisis system. 2 pieces to be aware of. One is it's not one system, it's multiple systems. Even within given regions, it's not just one crisis system. And ours is a great example. And I think also just if you're going to enhance something, it's best to really have a full understanding as to what it is that you're trying to enhance. And so that's some good efforts are being underway on that front to inform the process. And then just for the workforce shortage challenges, that continues to be a concern that we certainly voice without being too much of a naysayer to what's being aspired toward. But when we're looking at within this legislation creating multiple rapid response 24/7 crisis response teams in every region here across the state, I mean, that's if you really are going to do that in a fashion that does what would fully get the job done, it would take hundreds more staff, well-trained staff, and there's such a great shortage right now. That's already just a big hurdle. One of the other marvelous things that's envisioned is that somebody calls one of these lines, whether they're on Medicaid, whether they're uninsured, whether they're commercially insured, that they'd be able to, if desired and if appropriate, leave that phone call with a next day appointment with a mental health professional. Well, boy, given the challenges at hand right now with such huge workforce shortages and capacity being curtailed, with more than 50% of the behavioral health providers across the state having either closed outpatient programs or significantly curtailed access, the notion of being able to provide that aspirational level of access is really not connected with the reality of the situation that we have now and are going to have for some time. So it's good that there's a lot of opportunity for involvement in these discussions and these conversations. They are going to be quite involved and quite time consuming, but I'm hopeful that they will inform some good measured and informed thinking around how all this can evolve and move forward in a way that accomplishes as best it can at whatever pace it best can the goals of the legislation, while also being grounded in the practical realities. And we really appreciate, Justin, you being involved in that. I think it's very, very critical to have a BHASO voice, and particularly from our region. So thank you for being involved in those very involved in perhaps sometimes insufferable meetings, but necessary meetings.
Very much appreciate that, Jeff. Yeah, we're the Spokane Regional BHASO with the Spokane County is really excited to be one of the 2 ASOs selected as part of the CRIS committee, which really, again, leads credence to the voice we need to have from Eastern Washington for all of our 6 counties, and the impact this has for then looking at the implementation timeline of the next 3 years, but even beyond that. And so ensuring, again, that our providers and our leaders here with the counties have that ability to be able to share not only their concerns, but their direct involvement in how this is implemented is key, I think, to revamping the way we do crisis services moving forward. And I will turn it back over to you, Commissioner Kearns.
Okay, well, that brings us to item number 5, which is an update on the Spokane Regional Stabilization Center, and that is Dan Ziegler. So, Dan, feel free to unmute and take it away.
Okay, great. Hi, everyone. I'll keep it pretty brief, as I know we're limited on time, so just a brief update on this. So we are open now at the Spokane Regional Stabilization Center. And so if you can kind of go to the next slide, and maybe the next one after that. Yeah, so just kind of some quick updates on that. This is intended to be a jail diversion program for law enforcement drop-off for when they've come into the contact with people in the field who are in a behavioral health or substance use crisis, and also working with the behavioral health unit that's with Frontier and the police department and sheriff's department going out on the calls together. And so we're kind of a next level option when for the jail diversion piece, when arrests have been made or charges have been brought in those situations. Folks can come to us and the charges won't be filed, and then they can get treatment. So just a few quick pieces on here. It is set up to be kind of a drop and go for law enforcement. We'll do the medical clearance there at the facility. We have mental health crisis stabilization, and then medically monitored withdrawal management. And then we do have some co-occurring residential beds, so that if there's no beds available in the community, we can transition them into residential treatment while they're there, and provide some basic primary medical care and medication assisted treatment. And we can take referrals from rural areas as well. So and we can't provide transport in, but we can provide transport back after the person is through the crisis period. Go to the next slide. I did want to note some current limitations. One is that we're only, the total capacity for the program would eventually be 46 beds, but has also been, of course, talked about here. There are many challenges to staffing at this time, and so we have 16 beds open right now. We can provide all the services, so the detox and the stabilization and the co-occurring, but at a limited capacity. And of course, we don't do ITA. This is for those that would be the low-level misdemeanor charges, but aren't at the ITA level of care. So it's a voluntary option for the person who's encountered with law enforcement. And then so what we see is a lot of there's a list of charges that are approved by the prosecutor. It's mostly misdemeanors, and then some felonies that then could qualify for this program as diversion. So far, we have about 50 patients that we've diverted that have come in through law enforcement, but we did kind of a soft opening to just work through with the behavioral health unit, the drop-off process early on, so that it would go, so that before we went out more broadly to law enforcement agencies, we have worked through some of the bugs because, starting something new, there's always plenty of learning to be had. So we wanted to make sure we did some of that first. And so it's been really helpful working with the behavioral health units and with Frontier, kind of working through those pieces. So I appreciate all the partnership there. And if you go to the next slide. And then just as I mentioned there, because of the partnerships we have in place, we are able to then have a warm handoff for referrals for treatment afterwards, working with the other providers in town and also the MCOs who have the care coordination, particularly around the True Blood folks in particular, but more broadly as well. We do have some housing options available because of a grant that Frontier was able to obtain that allows also then for some housing we have 10 units available in our Pioneer housing, and then Catholic Charities will have 25 online next year. And then Frontier is able to provide the case management and the kind of the mobile crisis support services for the folks. We do have some peer support as well that's at the program that can also follow people after if they haven't been able to be connected. They might have fallen through the cracks for some reason. We can provide some peer support, and then transportation, as I mentioned, including rural, but within limits. But we have been able to already have a few folks who were in rural areas be able to get transported back to their community after getting some help. Go to the next slide. And then I just wanted to provide the referral information. So I think this can probably just be sent out maybe in the slides so that people have it. But there's of course, just normal phone line you could call, but then also there is an email that's looked at, every couple minutes, every 10, 15 minutes or so. And that's another way you can send in information to us. The officers will have a form that they can fill out that will have an incident number. And that's kind of how we'll track things. We will be talking more broadly with some of our, like I said, with law enforcement, both locally and in rural areas more in the coming months, but we can take referrals now. And that's really it.
Thank you, Dan. Any questions for Dan? If so, just feel free to unmute and chime in.
This is Jeff Thomas. I don't have a question so much as just to say congratulations. It's been a long time in coming. It's a big, heavy lift, and we sure appreciated the chance with our, our behavioral health units to be kind of helping to pilot it. But it's going to be a great resource, and I know you'll have the same challenges we all do with getting it staffed up. But congratulations.
Well, if I may just echo that, Dan, I just think this is best practice and really commend all your work getting this ready to go. So thank you, and we need to do more of this statewide.
Tony, I see you have your hand raised. Feel free to take it away.
Well, I put my comment in the chat. Tonti, everybody. Hello. I was pleased to hear Jason talk briefly about a commitment to equity issues, but you always do, Jason, so that is greatly appreciated. But I've not heard another speaker or presenter talk about the needs, resources for or our community connections for BIPOC people in Spokane. I'm the largest ethnic minority provider in Spokane. I knew nothing about these programs. We don't have relationship. We don't have connections. And I think we have to have this discussion. I mean, I think we have to really, I also feel kind of isolated in terms of representation here. I would really suggest, Commissioner Kearns, that we commit ourselves to one SCRILS meeting to have a discussion about BIPOC community issues and needs in behavioral health.
Okay, thank you. We can when we look to the next meeting, looks like it March of 22. We will try to have that on the agenda.
And let me and others probably help you shape that agenda, because I mean, we have to move forward together in this. Our community is really suffering from lack of resources, and this is the people that can help us save lives in the BIPOC community.
Ani, I'll make sure to get it on the agenda, and I may reach out to you ahead of time and just talk to you a little bit about it, as far as, you know, a little bit more about what you want and that are looking for with that, with regards to shaping it, and if you have any recommendations of speakers or anything like that that you'd like to have included, we can do that.
Okay.
All right, well, if there's nothing else on this topic, it's time for a Better Health Together update with Allison Paulson.
Commissioner, this is Sheree Spoke, actually Director of Integration for Better Health Together. Allison's daughter, it's her birthday today, so she's off doing 14-year-old birthday things. So I'm happy to jump in just for a minute. I know we're running short on time, but I will just kind of highlight the theme of the day, which is behavioral health supports and workforce, and would like to share just briefly some initiatives that we have to, again, I think supplement and enhance the offerings of HCA and our BHASO and the great work that both of those agencies are doing. So we have approximately 1.5 million of IMC dollars. That's the remaining IMC dollars that came to our region for becoming a mid-adopter, if you will. And we are really focusing and projecting 22 to spend those dollars down with our providers' input. We currently have a behavioral health work group that has been helping to shape and inform, you know, where our dollars and where our investments go around behavioral health. We are hoping to that group will become a formal collaborative in 22, and then go through a participatory budgeting process, so that really the funding is being spent, you know, with direction from the providers and what they want and what would be of most value to them. So it won't be BHT, you know, making the decisions. That will actually be the providers making those decisions about how do we support and how do we really further shore up a pretty beleaguered workforce, if you will. But some of the areas that we are anticipating and that the work group has indicated that they are interested in is really training in CEUs, which we know are very expensive, supervision, which we've done some investment with this year and will continue to. We really probably can't do enough of that. Evidence-based practices, training around that and opportunities. And so those are really the just three really quick areas that we are looking at investing funding. And again, that will be driven by our workforce or our providers, which include our rural partners as well. So it's not just Spokane, but it's obviously our rural partners as well. And so just wanted to share that real quickly. If people have questions, please throw them in chat or email me directly. I think as I look at the participants, I think half the board of BHC is on here. So probably more experts than I am for sure, but just wanted to share that briefly. Thank you, Commissioner.
Absolutely, thank you. Any questions, additional comments? All right, seeing none, I will hand it over to Kathleen to talk about the resolution approving SCRILS for up till the end of 24.
Thank you, Commissioner Kearns. As everyone I think is aware, we did send it out in November. The Board of County Commissioners did approve and sign off extending SCRILS through 2024, December 31st of 2024. And so we did send that out to everyone in an email, but also it is an agenda. It is the first handout in the agenda that was sent out by John earlier, I think last week or early this week. And so we just have a housekeeping item, is now that we have a new amended charter with SCRILS, we have to have it signed by all of the participating organizations. So that will be handout number 2. And the reason is just a line separation thing. It's just simply formatting. But what we would ask is not the county commissioners, but for the representatives of the organizations as listed in the charter, is that we would ask you to sign, I think it's the last page in it, but I don't have it up in front of me. And basically sign either electronically or a wet signature, and scan and send it back to Joanne Napier in our office. And she will look for seeing what we receive in the next 2 or 3 weeks, and then she'll start reaching out to representatives if she doesn't get your signed page for the charter, so that we can basically consolidate everybody's signatures into a single charter, so that we have everybody's signatures. For the county commissioners, Joanne will reach out to each of your clerks of each of the counties to obtain your wet signatures and incorporate that. So basically that's what Joanne and I were going to mention with regards to item number 7. Are there any questions from anyone? Great, thank you.
Okay. All right, so this brings us to public comments from community stakeholders. So I will just open it up. Anybody wants to jump in, feel free. All right, Jeff?
Yeah, thank you, Commissioner. People have probably heard enough from me, but I just do want to comment with a word of thanks to yourself and the other commissioners and commissioners from other counties and other providers who kind of lent voice to inform the decision to continue with the SCRILS meeting. I think it's something that creates an important and valuable forum for a multitude of reasons, as you know that I expressed. So just thank you very much for rethinking that and for continuing it.
Yeah, no, we wanted to, we had the discussion at the last SCRILS meeting, and we heard overwhelmingly from many members of the SCRILS board that there's value in it, and that the desire was there for us to continue it. So we that made our decision very easy. I mean, I think it's clear that there's value, and that folks told us they wanted to continue to be a part of it. So, all right. Well, if that is it, not seeing anybody else raising their hands or unmuting, then I think that does it.
Oh. Sorry. Oops. Let's see if I can try and get my camera on here. This is Laurel Lee, actually from Molina. I did have one question because I noticed that the charter had included United Healthcare as one of the MCOs serving the region, and that was probably because of the prior conversations. But I'm wondering if that should be corrected as we send it through for signature, now that we know that's not coming to pass.
That's a very good point, Laura Lee. We will look at that. Thank you.
Thank you.
Yeah, Dan?
Yeah, sorry. Yeah, I'm noticing that Laurel's on from Molina. And I don't know if the folks from HCA are still on, but I was curious if there was we were getting any closer to HCA allocating funds for reimbursement for intensive outpatient programs. That's a significant barrier, as I understand, for Molina in their ability to contract with providers throughout the state of Washington to provide intensive outpatient mental health programs to their members, because as we all know, barriers to care is a significant concern for everybody. Laurel, has the HCA talked to you at all about any movement there?
I am not personally aware, but I can definitely circle back with the folks here at Molina who weren't able to join the call, and we can get back to you.
Right.
And this is Teresa Clickamp. I'm sorry, again, I was catching part of that. When you mean intensive outpatient programs for mental health, is that currently a state plan service in our state plan and the SERI guide, or are you talking about something else?
Now, the language is kind of unique. So the other MCOs contract with the other MCOs in our region contract for intensive outpatient mental health programs. like your AmeriGroups and your CHPWs, et cetera. Molina does not, and not even on single case. And so per that, every single Molina member statewide does not have access to intensive outpatient programs, mental health programs. It's a significant barrier.
Yeah, and when you're talking again, and I'm sorry, I think there is language, and maybe we can pull this offline, because you're using language that's not familiar to me. So in the SERI guide, it's not intensive outpatient is not a state plan service in the SERI guide. So I'm just tripping off. So maybe somebody
I believe
we can
that's
take this offline.
Yeah, and I believe that's been the sticking point, is that the other
Okay.
MCOs see it as a value to their members in order to keep them from having to be hospitalized. And then Molina, per how large and how many members they have, and I don't want to speak for Molina, I can just tell you from meetings we've had with them, is that until HCA changes that language for reimbursement, then their members will continue to not have access to that care.
So Dan, this is David Nielsen with New Alliance. And for what it's worth, I have never heard the term intensive outpatient program applied to mental health either. And we have no contracts with any of the MCOs that talk about that. So I think as confused as Teresa is about exactly what you're talking about.
Right, because there's, as you know, Dave, there's PHPs, your partial hospitalization programs, and then your IOPs, your intensive outpatient programs. So partial hospitalization, is full day programs and they go home. Intensive outpatient programs mean that they're usually like 3 days a week for maybe 3 hours a piece.
So in the SERI, that would be day support services, day treatment services. So that's probably language that Teresa would better understand.
Gotcha. Yeah. Appreciate the clarification.
And we do have some pilot programs that are ongoing for intensive outpatient services, which is part of the project. In order for something to become part of the state plan, we actually have analysis that has to be done. So we're working through some pilot programs, and Mercer is actually the actuary that is doing that, helping us to inform that whole process to determine what that looks like, what the services would be. We're collecting data on that. So we are working through that, but as Teresa mentioned, as of right now, it's not part of our state plan amendment.
Right. Yeah. And that was my understanding. I was, again, just curious because the sheer volume of people that are hospitalized for inpatient, in like a freestanding or, a med surge that has inpatient. And then having individuals that don't have access to a lower level of care obviously creates more people that are hospitalized inpatient throughout a pandemic, right? When every bed is valuable. So I'd be curious as to know what the timeline is of the completion of that.
So the pilot project has been funded for an additional 2 years, and we have 7 programs. It might be 8, but there are 7 specific programs that are each doing different things at this time. And so we would obviously have to determine what the standards are, what the metrics are. So that's work that we're working through with HCA is working through with those particular providers who've been authorized to do that pilot program. We can keep you informed as we move forward with that, but you're right, it is a program that we've been looking into and working through to make sure feasibility, what exactly would the programs look like, what would the metrics be that would be the expectations for outcomes for the program as well.
And Michelle, and also I would just also add that one of the challenges with partial hospitalization and looking at adding that to our state plan is when we add something to our state plan, it becomes an entitlement and needs to be a statewide benefit. And partial hospitalization is hard to do on a statewide basis and get that robust network. So I think that's been one of the, if I recall it in my DBHR days, when we analyzed it before, that was one of the challenges is, ooh, I don't know how we would make this a state plan service.
Yeah, I'd be happy to provide any data you'd like regarding the amount of individuals that have coverage through another MCO like CHPW or AmeriGroup that end up not needing to be re-hospitalized because they do not have access to care, and those that have Molina. So as you're going through this, be happy to provide any information you need. I mean, I know you can get it from CHPW and AmeriGroup as well. I mean, you're the HCA, so, but I mean, it's something that breaks my heart on a daily basis.
Okay. If that's all we have on this topic, we'll just leave it. Anyone else? Final call for anybody else who has anything for the good of the order? If not, then we are adjourned, and our next meeting will be sometime in March 2022. So please keep your eyes on your emails for the specific date. Everybody have a wonderful evening, and we'll see you all in March.
Thank you.
Thanks, Commissioner.
Thank you.